Welcome to the Motivational Midwife. I'm Lynn Jones, and today we're going to look at antenatal screening. So let's have a look at screening in pregnancy. So I think before we start, it's important to actually differentiate between screening and diagnostic testing. So screening really is a test or a strategy that aims to highlight your chances of having a particular disease or condition, or in pregnancy we're looking at a lot of them to do with the baby's chances of having something. And a diagnostic test is more definitive. Okay, it will tell you definitely whether you have a particular disease or disorder. And if we look at screening from, say, the chances of having a baby affected by one of the trisomies, the screening we offer will highlight their risk either as a high or a low risk, and we would then offer them further diagnostic testing such as an amniocentesis, or some women have chorionic villus sampling if they're early enough in the pregnancy, and that would give a more definitive answer. It's important to remember when we are looking at screening as well that actually it's not a mandatory thing, and women have choice. I think historically women get pregnant and they just assume that the blood tests and the scans and everything that we offer them is a mandatory option, that they haven't really got choice. But actually they do have choice, and they can have all the screening we offer them, or some of it, or none of it. So if we have a little look at what we actually offer, we offer a host of blood tests. We offer scanning, we offer screening for trisomy, urinalysis, and I think one of the most important things is us as midwives, our surveillance of the pregnancy and the ongoing pregnancy. So if we look first at the blood tests, and there are the full blood count. These are all done or offered certainly quite early in the pregnancy, and it gives you a nice baseline to work from, so you know what that woman's normal levels are and whether there's something we need to perhaps treat quite early on. So the full blood count, although it gives you an awful lot of information about a lot of things, there's one or two things that we are most interested in as midwives. And the hemoglobin level, or the iron level, is one of the key things we're interested in. And normally in pregnancy, we'd like that to be above 11 or 110, depending which scale you're using. The HB in pregnancy women will have what's referred to as a physiological anemia. And that's because of the increased circulating volume. They have hemodilution, which makes it look like they're on a blood test that they are more anemic than they actually are. So with that in mind, one of the key bits to look at when you're looking at a full blood count result is the MCV, or the mean corpuscular volume, because if she is truly anemic, that will be reduced, and ideally you want it sort of above 80, 82. So anything below that, it means that she is actually truly anemic, and that does need treating. A very high MCV can indicate a folate deficiency though, so it's worth just bearing that in mind as well. And within that full blood count, you'll also get a platelets result as well. And platelets, obviously, generally they stay fairly normal level. They don't change very much in pregnancy, and the usual range is somewhere around 150 to 400. But if you're noticing that she has she's on the lower ends of that, or her platelets seem to be reducing at the subsequent blood tests that she'll be offered, then really as a midwife you should be referring her in to have that investigated further as to why that might be the case. And then white cell count. I mean, white cells obviously can be an indication of infection. A very raised white cell count can be an indication of infection, but pregnancy, there will be a slight raise in white cell count anyway due to the increased neutrophils. And also labour can and post-delivery, white cell count can be raised as well immediately post-birth. So it is important to eliminate or exclude infection. If she feels fit and well, then the chances are it is probably just a normal pregnancy thing, unless it's excessively raised, in which case it would warrant further investigation. One of the other blood tests we offer is blood group rhesus, looking for their rhesus factor and antibodies. Okay, so that's all done in the same sort of bottle, and their blood group and rhesus factor and antibodies are all very relevant in case she requires a blood transfusion, particularly antibodies, because if she has very unusual antibodies, it may be quite problematic to actually get a good cross-match if she required blood. And the rhesus factor, obviously, if we're highlighting women who are rhesus negative, then we can offer them anti-D prophylaxis and make sure they have all the information to make an informed choice about what that is and what it does, which I won't go into in this particular presentation. The other thing that we offer them screening for is hemoglobinopathies, so things like your thalassemia and sickle cell anemias. And in areas of the country where there's a high prevalence of that tends to be offered routinely. In areas where it is not so prevalent, then we're encouraged to fill out the family origins questionnaire with the women and really target those women who are at higher risk of having those hemoglobinopathies. For women who are at increased risk of gestational diabetes, so women with a raised BMI, certain ethnicities, first-degree relatives with diabetes, glucose tolerance tests are usually offered somewhere between 24 and 28 weeks. And we also screen for maternal infections. So routinely we would offer HIV, hepatitis and syphilis, but there are other infections that we can also screen for should the need arise, like toxoplasmosis. We can screen for listeriosis, cytomegalovirus. Rubella we don't routinely screen for anymore, whereas it used to be part of that maternal infection screening process that it's gone out probably for about the last 5 or 6 years now, I think, since it came off that. But it's important, obviously, to treat each woman as an individual, and if she has a particular risk factor, then it may be worth offering her screening for something at a given time. Chickenpox is often one that women come in and request screening for because they've been in contact with chickenpox. And also some of the blood tests will go along with the trisomy testing. So ultrasound scanning, again, and I know I've said this before previously, I don't think women really understand the purpose of scanning, particularly the anomaly scan around 20 weeks. We are looking for abnormalities. It's not just to find out what the sex of the baby is. And I think women need to really understand the purpose of scanning if they're going to make an informed choice about whether they have scans or not. We usually offer a dating scan quite early in the pregnancy. There is nuchal translucency scanning to measure the fluid at the back of the fetus's neck in terms of determining risks for Down syndrome. The anomaly scan, which we've said, which is looking for abnormalities, structural abnormalities in particular. In some areas of the country, there are gap scans. Depending on whether or not the trust you work for is adopted the gap scan protocol, you may find that there are women. This is a growth assessment protocol, so really it's looking to try and pick up those babies that are small for gestational age. In hospitals that haven't adopted the GAP program, then there will still be growth scan opportunities, but there's no sort of formalized process in terms of, as with the gap scan, if a woman's pathway deems that she is at higher risk of having a growth restricted baby, there are set pattern of scans that she will have through the pregnancy. In trusts that haven't adopted that they probably have a more fluid pathway, in that the midwife will refer in if she feels there is a need for growth scans, and if it is highlighted, then they will go on a path where they will have more frequent scanning. And then obviously there's Doppler scanning as well, which looks at the blood flow between the placenta and the fetus. So looking at trisomy, so trying to screen for those chromosomal abnormalities, we have, and not all hospitals do all things, so it's will depend where you are as to which of these things are in your area. But some hospitals now offer the non-invasive prenatal test, which is really a blood test from the mother, where fetal DNA can be extracted from maternal plasma. There is the triple and quadruple blood test. So triple is looking at alpha fetoprotein levels, unconjugated estrol levels, beta HCG, and if it's a quadruple, then there's inhibin A as well, and they're done quite early in the second trimester. And if it is combined test, really combines that with the nuchal translucency scanning at the same time. And the combined test ideally takes place between sort of 11 weeks and 13 weeks and 6 days. Triple or quadruple, there's a slightly bigger window, so if they miss the opportunity to have combined testing, then they can have just the blood test up to about 20 weeks. It's important for women to understand, though, that any of these blood tests can have screen positive or screen negative results, and that it's not, they're not a cast iron guarantee, that it's just highlighting their chances of having a baby that is affected. It's not telling them, yes, that baby is affected. And very often women don't appreciate that even if their result came back as 1 in a million, somebody is that one, and that could be them. So they do need to understand that it is, as I say, it's a screening. It's the likelihood of there being a problem, not there definitely is a problem. Raised alpha fetoprotein levels can often indicate sort of neural tube defects. And there are some pregnancies where some of this screening is not suitable for, particularly multiple pregnancies, because it's difficult to say which the levels are often affected and which baby is it. If there's been any intrauterine bleeding, if sometimes insulin-dependent diabetics, obese women, it can be problematic, and the levels can be affected. So urinalysis is something that we undertake. Oh, it's worth mentioning as well, though, that also raised nuchal scanning. If there's a raised level on a nuchal scan, it can also indicate cardiac abnormalities, not just Downs particularly. And the other thing, of course, that scanning, particularly the 20-week scan, is useful for telling us is placental location, which again can impact on the mode of delivery, particularly if it's a placenta previa. So urinalysis, when we're looking at that's something that we do every visit. And we are looking specifically for proteinuria or glycosuria, so protein or glucose in the urine, but it can also highlight infection. And obviously, if there was markers for infection there, you would send that specimen off for further investigation. But the protein and glucose can indicate either preeclampsia developing or diabetes, gestational diabetes developing. And again, both would warrant referral for further investigation. And our midwife surveillance, so this is us, what we do every time. And when you have continuity, you can pick up, in my opinion, more subtle changes in a woman's behaviour. If you see her all the time, you become more attuned to what's normal for her. And so you might be able to highlight issues in her mental well-being that, if we have a lot of different midwives seeing the same woman, may get missed. But we are really looking at her mental well-being, and particularly through this period of COVID, it's been very problematic, I think, for a lot of women. And a lot of women, I think, have suffered with their mental health. We're also screening blood pressure and urine, as we've said, at every visit. Blood pressure, obviously, if there's a rise in blood pressure from that booking blood pressure, and a significant rise, we're talking about not just a little bit, it's usually 15 to 20 millimoles rise from booking is deemed significant. And if she is otherwise symptomatic as well, so for preeclampsia, if she had any sort of visual disturbances, any epigastric pain, any edema, so swelling anywhere, and proteinuria, really would warrant referral in for further investigation. And we're monitoring the symphysis fundal height from about 25 weeks. We're measuring, and again, if you have continuity, you have the same person measuring all the time, there is less room for discrepancy, and more likelihood that you will, if you find that there's smaller than you would be anticipating, you're going to, or larger than you're anticipating, you can be fairly certain that it's not just a measuring discrepancy between practitioners. And then we're also discussing with women about their fetal movements, because fetal movements are a good indicator of how well that baby is. And for most women, although guidance doesn't recommend routine auscultation of the fetal heart, most women actually do want to hear their baby's heartbeat at every visit. And it can, although it's a snapshot in time, sometimes it can highlight an irregularity that would warrant you referring her into the hospital for further investigation. So if we look at how often we're seeing women to undertake this surveillance, really nice guidance suggests 10 visits for primips and 7 for multips, with that 18 to 20 week appointment really just being for their anomaly scan. So really, we don't have very many opportunities to see these women through their pregnancies, and COVID has certainly impacted on that greatly, in that women are not seeing midwives as often face to face as they were pre-COVID. So it is important that we arm women with adequate knowledge and educate them on when to seek further help in between not seeing us, and that they have some way of contacting us should they be concerned. And there we have it, antenatal screening. I hope you found that useful. If you haven't already subscribed to the channel, please do, and I look forward to seeing you next time.